Cancer MDT Improvement Programme. Today, we've got three great case studies looking at how we prepare for an MDT and some of the things that we can do to ensure its success. Usual ground rules and plan for the day is we'll have a session from each of the case studies, and we'll have questions and answers afterwards. So I'm not going to go through all these again. I think we've been through these a few times, but it's just that, you know, if cameras on where possible, so you can engage in the sessions. If you have questions, please contribute. Speak up if you're something you want to hear, or pop it in the chat, and we'll ask those questions for you. This is about learning. The whole program is about learning and taking information and knowledge away. So listen and take as much as you can and ask thoughtful questions if you need to, and stay open-minded to the ideas that actually there may be other opportunities to learn from others through the session. So we've got, first of all, we're going to hear from Derby and Burton, I think. Yes, Dr. Ketan Jethwa, consultant radiologist, who supports the breast MDT. We're going to hear from Royal London, Naresh Balsingham, and we're going to hear from Roysington, Wigan and Lee, Tasaduk Hussain, who's a colorectal surgeon and general surgeon. So no more to add from my perspective. Just remember that we'll take questions and answers at the end of each session briefly, and then we'll have some time at the end of the session today as well to wrap up a few other questions if you feel like you've had a bit of time to think and you want to sort of pose the questions to the three speakers. So without any further ado from me, we want to hear from the speakers today. That's what we're all here for. So Ketan, I'm going to hand over to you if you're ready to go. I think Robin's going to drive the slides for us. So over to you.
Great, thank you. I haven't got any slides, but I will share my screen in a moment or so. So yeah, thanks for the introduction. So I'm Ketan Jethwa. I'm a consultant radiologist at Derby and Burton. I'm also the lead clinician for the breast MDT, and today I really just wanted to have a chat about the triage MDT and how we can use that as a sort of a useful aid for preparing for the main MDTs that we have, and also how we can streamline the workflow within the MDT. So just as a way of an introduction, the Derby and Burton breast units are two large breast units which are subsumed under a single tract within South Derbyshire and Staffordshire. So our overall catchment area population is around 830,000, and our screening population within that is around 130,000. And sort of within that, both from screening and symptomatic services, we see around 800 breast cancers a year. So we're a pretty large trust and large breast unit within the region, and that's reflected in the throughput that we have through the MDT. So we have 4 MDTs a week. There's 2 main breast MDTs where cases which are recalled from screening or those seen in the symptomatic setting are assessed, and those are 2 hours, and those happen on a Monday and a Thursday. In addition to that, we have a smaller metastatic MDT, which is for patients who are known to have metastatic breast cancer and are under the care of the oncologists, and that's an opportunity for them to bring cases to us and say, is there progressive disease, and so how we're going to manage that, and so on. And we also have an oncoplastic MDT as well, where cases that are going for oncoplastic breast surgery are discussed, and those generally don't have radiological.
Another one. This is something different. He's got this today, and then the other one.
Oh, did someone have a question?
Carry on, Ketan. I think somebody was off mute.
I see. Okay, fine. As I say, so the last MDT is the oncoplastic MDT, which doesn't have much radiological input and is principally for determining sort of surgical approaches and treatment options. So the main MDTs that we have, which are the largest MDTs, as I say, where cases from symptomatic and screening clinics are discussed, are supported by a triage MDT that happens at 8:30 on the day of the MDT. So what I'm going to do is I'm going to share the working instructions that we have for the MDT office. So you should be able to see a Word document that's breast triage MDT at the top. Is that right?
Yes, you can see it. Yeah.
Perfect. So I'm just going to sort of talk through this document really. So the breast triage MDT happens on the morning of the main MDT. And core attendees of that include a breast surgeon from each of the 2 sites that we have, one at Derby, one at Burton, a breast care nurse again from each site, the breast navigators and the MDT coordinators. And I think having a great MDT admin setup is really important in terms of how these MDTs work, because it really helps streamline the flow of cases through both the triage and then subsequently main MDT, but also really helps with preparation as we'll see. So the admin team will collate the breast packets and the medical notes prior to the day of the triage MDT, and we'll look through each of the cases, and we have sort of an online platform that we use called Infoflex, where you can sort of identify whether patients need additional imaging, or if the results from histology are back, or results from imaging as well. And they sort of go through those cases and see what the purpose of discussion is, and whether any additional tests or opinions are outstanding. And then they split the cases into whether they are oncology or non-oncology discussions. And then once that split has been made, either the outcome of the MDT can be pre-populated. So, for example, if there's a case where the discussion will be between wide local excision or mastectomy or plastic breast surgical options, they can sort of pre-populate that on the system, so that when we come to the main MDT, we're not starting from scratch, so to speak. We're saying, okay, well, these are the options that we have. Let's pick the best one based on the burden of disease and other factors that may affect treatment. And a similar setup is also used for the oncology discussions as well. So whether you're going to continue treatment or change treatment. And again, as I say, that's really helpful for trying to streamline the MDT, but also, as I say, it helps with preparing cases. And of course, the clinicians who are at the triage MDT are also the same clinicians who will be in the main MDT, so there's that continuity. And any other triage cases which require discussion. So I'll move on to the triage cases. So we have, broadly speaking, 4 types of triage cases. So there are benign surgeries. So these are excisions of fibroadenomas, benign microductectomies or total duct excisions, mastectomies for symmetry, risk-reducing mastectomies, and benign excisions. So these are all cases that have already had a core biopsy diagnosis of a benign entity. We are looking to change this somewhat, so that actually, if there is a clinical abnormality which is classified as benign, the imaging is also benign, and then the core biopsy comes back as benign as well, whether that can be managed with the triage MDT rather than being discussed in the main MDT. So certainly we are looking to extend sort of the benign category from surgery to core biopsy as well, and that'll be an interesting sort of project that we're going to be developing over the next time. In addition to that, we're also looking at, can we actually reduce the number of benign biopsies we do in the first place? And of course, there's a lot of work that's been done in the imaging space, looking at whether we can increase the age at which fibroadenoma are biopsied and so on. The other types of cases which are discussed within the triage MDT are genetic test results, and again, the MDT admin office are very good at identifying the cases where these cases need to be put onto the triage MDT, and it really does save a lot of time in terms of the main MDT, where when you take these cases away. And then the other sort of 2 areas are backfilling of data. So, of course, there are national audits for the various tumour sites. So in breast, we have a national metastatic breast cancer audit, as well as a primary breast cancer audit, and we make sure that if there's any backfilling of data that's required, these are brought to the triage MDT, where, say, TNMs or receptor status and CNS involvement and various other data items can be backfilled. And again, the admin team are very proactive at looking at data returns and where there are gaps, and bringing these to bring these to that forum. We are also looking at including things like harm reviews and things like that as well, where if it's a simple case where actually there isn't sort of a significant error that needs to be discussed, then these can be discussed in that forum as well. So that's a very quick run through sort of triage MDT setup that we have at Derby and Burton. As I say, it is fantastic. It relies heavily on the admin support that we have, which is fantastic. And as I say, it does help with the preparing of the MDT and streamlining the main MDT as well. So I'm happy to take any questions.
Yeah, that was brilliant. Thank you for that. And I just love the way that it's simplified, standard work there. It's clearly understood, clearly written out, and there's a I guess that leads to a level of consistency that people understand what is required each and every time. So thank you for that. I really like that approach. A couple of questions. I'm going to go to Alison first, then Elizabeth.
Yeah, thanks for that. Can I just check the meetings, are they taken out of admin time, or are these PAs given? How's that time funded?
So the time is counted as DCC because of course it's clinical activity. So the surgeons and the nurses and so on will have sort of DCC time for this.
Thanks.
Yeah.
That's good. Elizabeth?
Yeah, thanks for your presentation. I'm actually a urologist, nothing to do with breast, but my question was very similar. You've got a lot of time in MDTs. You've got multiple MDTs, triage MDTs, and I was just wondering how this is all job planned in terms of, obviously, you've said it's DCC, but
yeah.
I mean, we'd never get that through job planning. And then in terms of admin afterwards, are you generating then lots of admin after each of these MDTs that then gets classed as sort of associated DCC time?
So each of the professional groups has their own sort of setup, if you like. So, for example, the surgeons within the breast unit have an annualized job plan. So that's sort of subsumed within that setting. But certainly, and the radiologists, we have a fixed job plan which is currently sort of under review, and we're deciding exactly how we're going to manage our work. But certainly, the different professional groups within the unit have their own ways of managing this, but certainly none of us feel that we're sort of massively burdened. And of course, with clinics and various other sort of other commitments that we have, that this is sort of an onerous burden on what we're doing. In terms of admin, so the MDT outcomes are generated within the MDT itself. So, for example, in a triage MDT, the outcome will be auto-populated or populated with an outcome that may require discussion. And then in the main MDT, it's decided what the outcome will be. That's documented and then printed out and signed within the MDT. So it's not like someone else has to sort of sign an MDT sheet after the event has passed. So certainly we have a degree of flexibility in work plans so that people are sort of rotated around different areas and sort of different activities. But no one sort of really feels that it's a massive burden on the time. And certainly from an administrative point of view, we try to do all of that admin within the MDT itself. Does that help?
Thanks both. Thanks, Ketan. I'm going to go to Robin first and then Tamsin.
Morning. Thank you so much for your presentation. I was just wondering, when this was introduced, or prior to this being introduced, whether you had any challenges or opposition to this very different new way of working?
So I think there was initially some reticence about cases not being discussed at and one of the things that we do in Derby, which I think is quite unique. So we have an annual planning day where all of the stakeholders within the department, that includes surgeons, radiologists, pathologists, oncologists, as well as the nurses, admin staff, and sort of helpers as well. We all sort of have an away day where we use this as a forum to discuss our unit guidelines, which as MDT lead I'm custodian of, but also to discuss any innovations and changes that we want to develop within the service. So certainly we have an annual forum, and one of the things that I've introduced over the past couple of years is, rather than just having it as a totemic annual thing, we sort of have a sort of a mini, if you like, annual planning day at 4 monthly intervals. So when we do want to introduce change such as this, we can sort of use it as a forum to voice ideas and hash out exactly what should go into such an innovation, and people can sort of voice concerns, voice ideas, and so on before we introduce it in real life. And then, of course, when one does introduce it, you introduce it in a piecemeal fashion. So certainly, when we first started, this was slightly before my time when this exactly started, but certainly when this first started, it was mainly for sort of documentation of data for cases and things like that, rather than sort of benign surgeries. And the one of the things that we're looking to introduce further is sort of benign biopsies. So which I think will be an interesting thing. Some of the surgeons feel a bit uncomfortable about, well, what if there's a discrepancy between the clinical and imaging findings and then the final biopsy, and how would that be captured, which I think is reasonable, but we're looking at developing safeguards so that actually only things that are concordant across the 3 ways in which we assess them are put through a triage MDT, and anything that is slightly unusual goes to the main MDT for a full discussion. So in terms of difficulties, I think that the main difficulties are those of sort of perception and people being, rightfully so, a bit wary of change and sort of how that's going to impact on services and safety. But I think the way to manage that, having regular team meetings to discuss those and to air those and to carry people with you as you go forward.
Great, thank you.
Brilliant. Thank you for that. Tamsin and then Suzanne.
Yeah, great. Thank you for sharing that information. I've just got a couple of questions. So one was about how you managed if you're doing the admin prep for the Monday morning meeting at 8:30, how that's done, because obviously MDTs on Mondays are always a bit challenging.
Yeah.
And my second question was around, and I'm sorry if I missed this, but around the impact that you've seen it have on your main MDT in terms of what kind of, has it meant you've been able to have longer discussions, or you've been able to shorten the meeting? Yeah, just be really good to know that. Thank you.
Yeah, absolutely. So I'll start with the second question. So with certainly the triage MDT has reduced the burden of cases that we discuss. So breast MDT is obviously one of the largest MDTs within the hospital. So certainly at a stage where we were having sort of 80 to 90 cases per MDT, which is a significant cognitive load for everyone involved. And certainly taking out sort of cases where you can where they can easily be removed has significantly reduced the number of cases. So whereas at its height we were sort of having MDTs of 80 to 90 cases, they're now in the order of 60 to 70 cases. And the other thing that we do as well is that any case that is not ready for, where the pathology, for example, is not ready or the imaging isn't reported, that is automatically taken out as well. That sort of helps to smooth out the MDT so that you're not sort of preparing a case or looking at a case where the pathology isn't ready or the imaging isn't ready or whatever. So certainly that has significantly had an impact on the number of cases within the MDT, the cognitive load associated with that. The MDT still is scheduled for 2 hours, and generally speaking we tend to fill up that time, but that time generally is spent on discussing the more complicated cases, because of course you're freeing up time from these other cases. Monday MDTs are always difficult, but the way we manage that is that the MDT office send out it depends on sort of individuals' working practices, because some of my colleagues do things slightly differently, but certainly what they do is they send out a MDT list on Friday lunchtime. So for those colleagues who want to start prepping on the Friday afternoon, or potentially on the Friday afternoon, they have that available. And then the triage MDT happens on the Monday morning, and those cases which have been done and been taken off, they sort of let the surgeon and the radiologist and the pathologist know, so that when they're sort of doing their prep in the morning before the MDT itself, they know which cases need to be discussed and which cases don't need to be discussed. So, for example, the radiologist gets the breast packets at roughly 10:30. So we've got that sort of 2-hour window before the MDT starts to through the cases and review the pathology and the imaging and so on. And the same is true for the surgeons as well. So that's how we manage the Monday AM, well, the Monday MDT.
Great, thank you. Hope that answers your question, Tamsin. I'm going to go to Suzanne.
Thank you. Can I just ask, do you record your triage MDM on Infoflex?
Yes.
You do?
Yes. So that's recorded on Infoflex, and if it's a case that's discharged from the triage MDT, then then you get an MDT outcome from that meeting. And if it does go to main MDT, whatever's discussed at the triage MDT is documented, and then of course amended at the main MDT.
Thank you.
Brilliant. Thanks, Suzanne. Olamide?
Hi. Thanks for that breakdown and overview. In fact, it's very insightful, actually. I'm a gynae oncologist and chair the MDT at New Cross in Wolverhampton.
Yeah.
I think in the last couple of weeks we've made changes. Our MDT, as of yesterday, holds on Monday afternoons, evenings actually, 4:30 p.m. to about 6:30, and you can imagine by 6:30 you're really tired and you just want to get out. So we're trialing a 6-week period, over a 6-week period of moving the MDT to 3 p.m. Now, for your triaging, how long does it take, and is that job planned as well? And secondly, you talked about the MDTs on Mondays being prepped for on Friday afternoon. Most of our radiologists found it difficult with the MDT list being released on Friday for a Monday afternoon, and wanted at least 48 to 72 hours to prep for it. So we've now changed the final MDT to being released on a Thursday afternoon. So So have you found that difficult at all in terms of coming from your radiologists?
Yes, I'll deal with those in turn. So the triage MDT lasts an hour, so it starts at 8:30 and ends at 9:30, and that's sort of before the beginning of the working day, if you like. And as I say, the core members of the team who attend the triage MDT are the surgeons, the nurses, navigators, and admin team. So they have, well, certainly the surgeons have that job planned within their working day, and that's DCC. Now, in terms of radiology, so I'm also a gynae radiologist, so I also do a gynae oncology MDT, but I won't go into that. But certainly, the way we do things within the breast unit, the radiology prep time is, again, job planned. So what we say is that if an MDT is a session, then you get a session of prep time. So depending on people's individual job plans and what they're doing at any given time, they are given sort of within the constraints of that, they are given time to prep the MDT. So for example, I'll just talk about the Thursday because that's easier, and then I'll go to the Monday. But on the Thursday, the MDT is in the afternoon. You get the whole of the morning to prep the MDT. So you get the packets at sort of 10:30, so you can prep the treatment decision cases that have been recalled from screening, or the symptomatic cases, and you use the sort of the 9 till 10 time to sort of report any CTs that aren't reported, or review CT scans and other cross-sectional imaging. So that's how we do things on Thursday, and then of course you have the MDT. On Monday, the Monday morning is dedicated for MDT prep time. So the MDT starts at, we're slightly unusual because our MDT starts at 12 o'clock, and that's a historical thing because of oncology availability. But basically between 9 and 12 is your MDT prep time. And generally speaking, we don't have patient-facing clinical activity in the breast unit on a Friday afternoon. So if you are going to be doing the MDT on a Monday, generally speaking, you're reporting or you've got some downtime in some shape or form to prep the MDT. And I think it's just within your service how you sort of manage that in terms of radiology availability and things like that. But certainly where we are, it sort of works quite well in terms of giving people a bit of downtime on that Friday afternoon if they do want to start prepping. But if they're doing something like hot CT or something like that, then that's a bit more tricky. But certainly you get that prep time on the morning of the MDT anyway. Does that help?
Yeah, it does. It does. Thanks.
Thanks, Kid, and thanks for that session. Generated lots of questions and lots of interest. So really, really helpful. Thank you. Sabita,
yeah, I mean, if anyone wants to sort of find out a bit more, I'm more than please do reach out and we can have a discussion.
If it's a quick question, Sabita, we can come to you now.
Oh, thanks, Nick. Very insightful, as Mr. Offenren was alluding to, and thanks for everyone. My quick question is, when you say prepping, is it in obviously the individual specialty teams are involved in the prepping. Of course, the lead, MDT lead is the one who is doing the prepping most of the time, is it? Or is it all the core members involved in that prepping process?
Oh, so, well, I mean, obviously different specialties will prep the cases in the way that they need to. So as I say, as MDT lead clinician, I don't do every single MDT. So we rotated amongst the radiologists, and sometimes, I'm not always at the MDT, if that makes sense, because I might have other clinical activities and things like that. So one of the things that we have in Derby is that certainly amongst radiologists, we're all flexible in the sense that if we have a breast session, sometimes that might be MDT, sometimes that might be clinic, sometimes that might be something else. So we all sort of rotate around so that we get sort of variety of activity and all of that sort of thing. So there is sort of variety and sort of change within who does what at any given time. So just because I'm MDT lead doesn't mean that I sit in on every MDT. And the surgeons have a similar sort of setup as well.
Thank you.
Yeah.
Brilliant. Thank you, everybody. That's really insightful. And Ketan, thanks for your time. That's has been so helpful, everybody. Thank you.
No, thank you.
And I'm sure the chat is still open. So if anybody wants to ask any more questions, then I'm sure we can pick them up there. So I'm seeing Naresh is waiting patiently on the screen to go. I'm going to introduce Naresh Balasingham, who is colorectal MDT coordinator from Royal Free. Robin, are you showing slides? Naresh, are you sharing slides? No.
No slides for me.
No slides for you? Oh, God, you're going to go rogue. Okay, so, sir, over to you.
No, thank you, Nick. Thank you. I'm just going to keep this short and sweet, really. Nothing too complicated, just as an intro. I'm Naresh. I'm the colorectal MDT coordinator here for our trust here at the Royal Free. I'm lucky enough to be joined here by two of our very supportive cancer performance managers as well, who have been very, very supportive and helpful to me. I'm just going to go through a quick whistle-stop journey of our improvement journey for our MDT, which has lasted essentially for the last 3 years. Let me start off with a story. When I first stepped into the role, at this point 3 years ago, I thought I was here to support the MDT, send out invites, prep the list, take notes, important stuff, sure, but then one day, during my second ever MDT, actually, our clinical lead, who was chairing at the time, turned to me and said, "Why is this patient on the list, Naresh?" And I didn't know. Frankly, it was quite embarrassing. But it made me reflect. It actually caused me to think, because if I couldn't explain why that patient was on the list, if no one in the MDT could explain why that patient was on the list, maybe they weren't ready to be discussed. And actually, it made me think that an effective MDT is only as good as its prep. So we did something about it. We sat down with the clinical team, and we built a referral performer that was simple, standardized, and focused. My clinical lead and various consultants gave me a lot of feedback. They're very engaged and very, very helpful towards me. To keep things succinct when it comes to prepping the MDT list, when it comes to the actual information that we need on the crib sheet, the info that we need is where's the patient from most first, if they're a target referral, if they're an inpatient, for instance, if they're a referral from another service, a short summary of relevant past medical history, and the key diagnostics. In colorectal, for instance, for colon cancers, it's the gold standard colonoscopy that we need, and a staging CT chest, abdomen, and pelvis that they taught me. And for rectal cancers, it's still the gold standard endoscopy, but also a CT chest, abdomen, and pelvis, and also an MRI rectum, which we need as well. And together, and of course, like the most important thing that I realized for the clinical team is a clear clinical question to the MDT, because if there's no question, there's actually no discussion. And review imaging is not a question. We need to focus the radiologist's time and the surgeons and oncologists' time as well. So that referral performer made a massive, massive difference. To give you an idea, we did an audit and a baseline audit at the time, 3 years ago at this point. We had around 50 cases that were discussed in our main treatment MDT every Friday. And now it's on average 35 cases. Often, depending on the time of year, it's less, sometimes more. And that space has allowed us time to think, time to breathe, and focus on the patients that actually truly need discussion. And also my clinical lead, who's been very, very supportive to me, has also given me the advice that a referral performer isn't there to deter referrals. It's there to ensure that the patients that do get discussed get the proper time and quality of discussion needed. We also restructured the list in terms of prepping. The more complex cases, ones that need nuclear medicine, for instance, the newly diagnosed patients, they go to the top of the list when minds are still fresh, and more simpler algorithmic ones, maybe such as post-op histo, go at the bottom of the list, because nobody wants their loved one, for instance, to be on the last page of an MDT. Everyone's tired when it comes to like hour 3, for instance. The coffee's tired, even I'm tired typing the MDT outcomes. But if you structure the order in a way, it combats decision fatigue, we found. Another big shift at the time was we introduced a consultant chair of the week rota. So we divvy up chairing responsibilities. And they also now have a job plan pre-meet time to go through the provisional list with me, which we defer cases if staging investigations aren't ready, if things need to be ordered, for instance, so that we have all the full information ready to make a plan for the patient. They give me advice in terms of, oh yeah, you can send this back to the referring team. We'll see them in clinic, for instance, if it's a benign case, if it doesn't need MDT discussion. And that's worked really, really well. Truth be told, there was some initial pushback when we tried to introduce this, as with every team. There's a lot of time pressures. Everyone has packed schedules. However, I'm really lucky enough to have an engaged clinical team who actually invited me to an away day to present why we need a referral performer and also a consultant chair of the week rota as well. What really helped was presenting the quantitative data at the time. At the time, we spent around, roughly on average, we calculated 2.5 minutes per patient per discussion. And now we've done an audit and it's near 7 minutes. Also, what helps is framing it not as extra work, but as an investment to the quality and flow of the MDT. We also use the day to gather survey responses as qualitative feedback to what was happening at the time. And actually, my clinical lead and I are in talks about rerunning that survey post-improvement work as well. We also tightened up referral deadlines to ensure that the radiologists and histopathologists have time to prep. I'm glad this follows on from Ketan, who I understand is a radiologist. It's important to respect their time as well because they need to prep for the MDT. So if a referral does come in late, so our MDT is on a Friday, our deadline is on Thursday morning, 9:30, and the radiologist's a job planned Thursday morning to prep for the MDT. But if a referral does come in late, I always check with our excellent CNS team who support me. I sit with them, which makes a massive difference as well. And our consultants who's chairing on that given week to decide if that referral should wait or should it be discussed now, because that decision must always be clinically led. For instance, in colorectal, if bowel obstruction is a medical emergency and that can't wait. In fact, it's such a medical emergency that often the decision will be made outside of MDT. For instance, if a patient comes in obstructed over the weekend. And I just want to reiterate to everyone who's here and people who listen to the recording well after the fact, an MDT is only as effective as the prep that leads up to it. And everything works with teamwork. Every single day, I'm constantly liaising with our consultants. I'm on the phone with our CNS team, constantly checking, oh yeah, has this scan been done? Has this been reported? Is everything ready for this patient to be discussed this week? Even this week, in fact, yesterday, I was looking at a CT for one of our patients who was due to be discussed, and it needs an MRI liver for further clarification. And our CNS team said, oh yeah, Naresh, thanks for flagging that. Let's not waste time. I'll call the patient and we can get that done before our Friday MDT this week. In fact, that patient's coming in today for that MRI liver. And hopefully having it done as we speak so we can have everything ready for our MDT. And the take-home message just from today in this little talk is just to empower your MDT coordinators because we'll give a lot back to the MDT as well because personally my feeling as an MDT coordinator is we are here to enable the clinical team, you all, to be the best that you can possibly be. And in fact, it's gotten to the point where now our MDT is the funnest part of the week for me. And I constantly say this to my line manager who's on the call with me today. I don't think she kind of believes me, but now we have our consultants and CNS team who've started a pool as well to have coffee, tea, and biscuits in our MDT as well, which helps combat decision fatigue. But that's just a quick whistle-stop tour regarding how we've improved the way that we prep, introduced a pre-meet as well, which has worked really, really well. And for anybody doing an improvement plan for any changes within a service, MDT or whatnot, start small and think big, really. And I'm glad that we have a consultant colorectal surgeon actually going after me as well. That leads on nicely. But yeah, any questions?
Brilliant. Thank you, Naresh. It's really interesting. Fascinating insights. We're going to go to Ahmed first and then Robin.
Yes. Thank you very much. It was a really very good talk. And you touched on the most important things, that you are the backbone of any MDT. We appreciate that. And you done it by your own, like, fact finding. But if you are going to progress tomorrow for another job, that's what we want to do from you. Like, you're the one who's going to sit in your place, what you are going to leave for him, because this is what's happening to us. Like, keep changing the MDT coordinator and everyone have to start from scratch back again, finding the way. So I'm just thinking of, like, between MDT coordinator, whether you can set up a guidelines or like access system or like something, like, rather than another person come and do this exactly the same, go through the painful process of getting all the fact back again. But I really extremely happy, like, and I want to congratulate you for the good work. Thank you very much for that.
Oh, thank you, Ahmed. That's actually a really, really good question. It's all about sustainability, right? In fact, it's not even just when I leave. When I go on annual leave, for instance, that's part of our compensation for working in the NHS and in the trust, right? Together with the clinical team, we set up an SOP for referrals, so standard operating procedure. What we do when we get a referral, for instance, we flag it to our consultant clinical lead. And in fact, just recently, I had some time off, and Zoe, who's on the call today, it worked out quite nicely because our consultant who was chairing that week had a pre-meet with them and advised them, oh yeah, this patient's for discussion, this patient's not. And it really taught them, actually, which was really, really nice. I don't know if that worked for you, Zoe.
Yeah, it did fantastically, actually. And I think one thing Naresh does very well is not only is he thorough when he is here, his handover is exceptional. So we can give that out to the clinical team to know what, if there's new members of staff joining there, what they can expect and how they contribute to the MDT, but also at the same time for us, if whoever is covering him, he literally goes into the fine details of how he preps the, even the Word document of the list. So everything is the same. All the details are there that they've, as a group decided that that's what they need. Yeah, the rest preps everything extremely well, which I'm sure is no surprise to everyone after his speech. But yeah, everything is superbly organised.
Thank you, Zoe.
We've got Robin.
Robin.
Or...
Hi, Naresh. I was just thinking about how often when you improve prep for MDTs, it can lead to perhaps more workload for MDT coordinators. And I just wondered how you balance that and overall what you think the benefits are of having good prep for an MDT for you in your role as an MDT coordinator.
That's a really, really good question, actually. And truth be told, when we first introduced all this additional prep, I guess, for the MDT, especially when it comes to like the Word document, the layout of the list and whatnot, it takes time. You get a lot more efficient at prepping the list, that's for sure. Now, for instance, I can prep a list in as little as 5-10 minutes, right? And I give that time to myself every week to do that. But initially, it took me, 1-2 hours because you're going through all the scans, making sure that that things are done. And I totally understand and respect colleagues when they do cover me. It will take more time as well. In terms of how it's helped with the prep, it's meant that patients aren't added to MDT unnecessarily, for instance. We're not adding days to the patient pathway. We also have a much more fun MDT, for instance, as well. It's a lot more streamlined and a lot more flowing. Yeah, it just gets better with time, truth be told, Robin. Yeah, don't know how else to answer that question apart from, yeah, it takes time. There is what is it? I was speaking with one of the other MDT coordinators in another trust, and they've actually set up a macro, just a button that they click, where it essentially does all the formatting of the MDT Word Performer and crib sheet, which sounds amazing. I would love to pick his brain on how they got around the IT things around that, because I can set up a macro, but I'm sure that our IT systems will block it. Yeah, maybe that's something, food for thought, a macro.
Great, thanks, Naresh. And yeah, I think the key bit there that you mentioned was about it's just continual, isn't it? You never get it right first time and just figure it out. Adele, I'll come to you.
Hi, thanks. Naresh, that was great. I'm a urologist. In my previous life, I used to be the Associate Medical Director for Cancer Services for our trust. And during my tenure of this, I used to run regular professional development activities for MDT coordinators, realizing that they are the backbone of the MDT. I wonder whether that is being adopted by everybody, because I think the quality of the contribution of the MDT coordinator to the working of the MDT is the one single most important factor to improving the MDT running. So I'll just be interested whether that is happening regularly, and it has to be, and it's not a one-off episode of training or development. It has to be integrated in their working life. And before I shut up, I want to ask you, how do you deal with this bugbear of mine when a radiologist or any consultant or somebody like that for an ad hoc patient who they are dealing with in any clinical setting, just casually say, I recommend discussion in the urology MDT, because medical legally, that is a minefield. If your pre-MDT meet decides that this is not appropriate for the MDT, then you have overruled the professional opinion of somebody else, and you're leaving yourself vulnerable for criticism if anything goes wrong. I keep trying to dissuade colleagues from putting this casual discussing the MDT. This is not a rule. You can refer to a urologist, you can refer to a colorectal surgeon, and then they will decide whether this case needs to be in the MDT. But I failed miserably, not least because of the amount of work outsourced to reporting by somebody in Australia who said, who puts in, discussing the MDT. Thank you.
Thank you, Adele. We've actually come across all of those in my time here in MDT. To touch upon the first point, which is professional development and training, Robin and the national team have a great network for MDT coordinators, which we post a lot of insights and shared learnings throughout the country, for instance, because different MDTs and different trusts operate differently. They have a great at the National Disease Registration Service website. They have a great, simple yet succinct presentation slides on each tumor site when it comes to staging, what scans are needed, for instance, which is great for new starters. It's helped me when I'm covering other tumor sites, for instance, as well. In terms of training, for me, the gold standard, and I will die on this hill, is to sit with the clinical team. Every single week, I'm lucky enough to sit with our CNS team, and you learn through osmosis. And even for them, they learn in terms of like policies, what we need as well. So it's a quid pro quo. You help us, and we help you. So that's my thoughts on the training aspect, because that's been continuous for me. I'm learning every single day. In terms of the radiology reporting, we also have a radiology red flag system that says refer to colorectal MDT, for instance, refer to urology MDT. And the query might be, query neoplasm, query diverticular, query fistula, which isn't, sometimes they might say refer to colorectal MDT, and you're looking at the report and there's actually not, the question is not cancer. It's a fistula, which is serious, but there are other ways of managing that. We've flagged it with our clinical lead, and actually sometimes the most appropriate action is not to bring it to MDT, especially when no one has actually met that patient, because a smooth MDT, the way it runs is, we've found, somebody at least knows that patient, has seen that patient, whether has spoken to that patient, whether it be our CNS team, our clinicians. So I bring that to our pre-meet. I flag it to our consultants, and they will tell me, oh yes, for face-to-face clinic, we'll see them, or for routine, and we actually document that on our patient record systems. That's the way we do it, and I do definitely understand where you're coming from in terms of medical legal aspect as well, especially when it's reported by an outsourced radiologist, for instance, as well. And in that case, we'll flag it to our lower GI radiologists who are very responsive and very engaged. That's the way we go about it in our trust, and the way that I think regarding training, for instance, as well. We also have, a great supportive cancer performance management team who always support us and offer training sessions as well. We have a monthly cancer services MDT meeting where we have cancer waiting times quiz questionnaires as well, which makes me remember stuff as well, and I always learn from it. But that's my answer.
Fabulous. Thanks, Naresh. Suzanne, last question to you.
Sorry, couldn't come off mute. Thank you, Naresh, for your presentation. It was really interesting. And just as an observation, I have found within my trust that the MDT coordinators that really are engaged with the process, understand the process, who want to make a really good job, are the MDTs that work the best. I've got a few staff members that are just there and go through the process, but I agree with Naresh, if you're really interested in the role and support your teams, they are the best MDTs. So well done.
Oh, thank you. It's all about job satisfaction as well, right? It's not just MDT,
definitely.
It's not just NHS, it's anywhere.
Yes, definitely. I agree, but thank you.
Brilliant. Thank you, Naresh, and thanks for all the questions as well. That's really helpful and a great discussion. Really insightful. Thank you for that. We're going to move the agenda around a little bit because I think Tasaduk is a little bit delayed at the moment. So I'm going to invite Elizabeth Bright from Cornwall to step up to the stage. I think Robin's got the slides, going to share and drive for you. Let's just give Robin a chance to do that. Yeah, there we go. Can everybody see the slides? There we go, moving through. Nice, lovely. Elizabeth, over to you.
Thank you very much. Thank you for asking me to speak again. I spoke at the last session and that was on standards of care, so I haven't covered that in this session. This is more again about, I think, highlighting the importance of your MDT coordinator and being quite ruthless with what you do and don't do in your MDT. So if we switch to the next slide. So preparing for an MDT well, first of all, I think what you have to do and what we did was we had to identify the problems. So we had long MDTs with lethargic clinicians. We had radiologists and pathologists that just didn't want to attend. We had incorrect clinicians attending. And we had people with no interest in the cancer MDT come into the cancer MDT. We had patients listed for discussion with incomplete data, which was pointless. We had patients listed who nobody knew, pointless discussion. And we were discussing patients where the discussion didn't change their management, and we knew it wasn't going to change their management. So what was the point in discussing them again? And the worst thing in my eyes at the time was we had laborious and repetitive admin processes that absolutely needed updating and changing. To flick to the next slide. So what did we actually do? So in total, we made 13 changes to the way that our urology MDT ran. The vast majority of those were admin processes, but we did actually change some personnel who was coming. We distributed workloads differently. We implemented effective follow-up clinics, which had a huge impact on our admin. And we, as part of this, we also agreed and implemented standards of care, which meant that some patients didn't ever need to come to the MDT. This was all designed by myself at the time when I was cancer lead, and in coordination with our MDT coordinator, who again is very engaged, very efficient, and very much part of the urology team. This was all then agreed at an away day. We've heard about away days before. I can't stress the importance of these. What we did was, it's essentially a business policy meeting that every MDT team should, in theory, have once a year. But we just increased ours a little bit initially to once every 6 months. And we got all the managers to agree that for half-day session, we could all go off-site. So we weren't hassled and asked to be pulled off to clinic or wherever. So we could all sit down and agree all these changes. And we did that by proving to them that actually our time would be used more efficiently, we would improve patient pathways, and they would actually also see some of that within their financial budget improvement. So flick to the next one, I'll explain out some of these in a bit more detail. So firstly, changes in personnel. I think you have to be ruthless. I limited the MDT attendance to only urologists with an interest in cancer. So of the urologists, 5 stayed in and 4 were kicked out. And our managers actually loved that, because if you can imagine, on a Thursday afternoon, every urologist in Royal Cornwall Hospital went to the MDT. Nothing else happened in urology on a Thursday afternoon. And 4 of those people probably didn't contribute anything to that meeting. We also sectioned the MDT, which a lot of hospitals did and do currently, but for some reason Cornwall never did. And so we sectioned it into patients that only need a pathology discussion, those that needed pathology and radiology, followed by those that need only radiology. And that meant our pathologists could leave early and get on with looking at slides. Our radiologists could come later, and prior to that could be reporting some more CT scans for us. So again, more effective use of their time. If we flick to the next slide, these are our admin changes, which is the vast majority of what makes you prepare well for an MDT. So firstly, we set a rule that only members of the MDT panel could add patients to the MDT. Prior to this, we had every Tom, Dick and Harry around the hospital adding patients. Some of them didn't need to come to the MDT. Some of them didn't even have a urology cancer problem. And it was just a disaster because, again, there were patients who we didn't know. Everybody was looking at each other saying, why are we discussing this patient? An absolute waste of time. And we used the MDT coordinator to act as a gatekeeper for that. She was very much given carte blanche to say, hang on, I don't think this needs to be added. And if she knew it didn't need to be added, that was fine. She went back to the referrer with an appropriate other pathway that they would go to, which might be something like an outpatient clinic. Or if she was unsure, she came and verified that with the cancer lead or one of the cancer nurse specialists as backup. We created an electronic add to MDT form. Now we've got a sort of electronic patient record that we've had for 15 years in Cornwall. So we don't need to look at patients' notes. It's not Cerner, it's not Epic, it's not one of the big ones, but it works really well. And on that, there's probably about 300 different patients' pathways that you can refer patients to, be that MDT meetings, outpatient clinics, or whatever. And we'd never used that for our MDT. And what we were doing was emailing cancer services, or secretaries were emailing, or CNSs were emailing, consultants were emailing, radiology. Cancer services were being inundated with emails. Half of them weren't ever getting looked at in time before the MDT. So we just said, no, certain people use this form, add this way. It creates an audit trail that can be seen on the patient's EPR very quickly and effectively. And people then don't have to be phoning people saying, is this on the MDT? And then at the other end of that, we created an organ-specific MDT outcome pro forma. So the urology MDT is slightly different to, say, colorectal or breast, in that we are dealing with multiple cancer sites. So we deal with 5 different organ cancers. So the pro forma had to be similar, but slightly different to reflect those. But what that meant was it allowed the MDT coordinator to spend her time not typing everybody's name, all the pathology again, and reiterating things, but actually using drop-down pro formas, which I'll show you in a minute. So it sped up her typing, it sped up our MDT. It also meant that then, within 12 hours, was automatically uploaded to our EPR. So anybody around the hospital could see that that patient had been discussed at the MDT, and this was the proposed outcome. And this was really good for patients who are admitted, say under the medical team. They're wondering if we know about the patient, if we've discussed them. And it was also good for our cancer services team to be able to constantly tracking things. What we also did was we implemented post-MDT clinics, which is something we never had for some reason. And we created, so our MDT is on a Thursday afternoon, we created MDT clinics that are either run by, well, there's MDT clinics run by consultants, there's MDT clinics run by cancer nurse specialists, some of those are face-to-face, some of those are telephone, but they all happen on a Tuesday. And the reason for that is because it gave us time to get the MDT pro forma uploaded on a Friday, can't see a patient on Saturday and Sunday. Monday, there's 2 bank holidays in a year, so the next safest day for it to always happen, 52 weeks of the year, was a Tuesday. And that cut down a lot of admin as well, because we knew that we would be seeing the patients on Tuesday and things would happen at that point. The twice yearly or yearly is just referring back to the away days, which I can't reiterate the importance of, because once you've implemented changes, you have to then have an away day, I think, within 6 months to make sure everybody's happy with those changes. Are they still safe? Are they working effectively? Do we carry on as they are, or do they need to change? Do they need to be tweaked? And that process of iteration and reiteration is really important to basically make sure that the pathway is working, but also everybody feels comfortable with that. We flick to the next slide, please. So this is just an example of our add to MDT form and our EPR. It's called Maxims. Some people around the country might have it. At the top, it would have the patient's details, but I've obviously taken those off for confidentiality. This is just an example of an elderly man that I added for bladder cancer. So you can see at the top that my name's on it, Elizabeth Bright. I'm the recording user. I'm the person adding. The clinical details on the left of your screen. What I've written there is essentially everything you need to know to discuss that patient at the MDT. It's short and sweet in neurology if you think about it in the right way. And so the MDT coordinator can lift that directly and put it onto the MDT list. On the right-hand side, at the top, there's a note for users saying, if you ain't part of the MDT panel, don't use this form because it's going to get rejected. Go and speak to somebody else, talk to the CNSs or talk to the urologist. Then underneath that, there's a list of cases that we don't review because they are part of our standards of care. And that's just to remind people who are even part of the MDT panel that, oh yes, that one's right. That one goes on the standard of care, not a discussion. We put down who the responsible clinician is. And most importantly, we put down who has agreed to present the case, because you don't want everyone looking at each other going, I don't know this patient, I didn't agree to discuss it. The relevant history, I always just put see clinical details because I use the other side. Then there's a drop down saying which section you want it added to. And for this patient, I've added to pathology only. And again, this is because our patient's had a CT scan. I've written there that it's normal and it's been reported by one of our uroradiologists that sit in our MDT meeting. So we've agreed that if they've reported it, we don't re-report it through the MDT if it's normal. And then we put down their performance status because that's really important to know. And then our proposed MDT question. So here I've put, is he going to have BCG or is he going to have endoscopic management? So that's what we add to. It saves a lot of emails. If you flick to the next slide, you'll see how that then translates to what we look at in the MDT. And so this is now a Word document and it's a continuous stream of patients, you know, up to probably 40 patients. He happens to be the third patient on the first section, which is histology only. He's under my name. He's a bladder cancer patient. And then the middle section is populated from what I've written, the clinical details. And then underneath that, the MDT coordinator has cut and pasted the conclusion from the pathology report because it's only pathology we need to look at. The final column is our bladder MDT outcome. So these criteria, discussion, outcome, further tests, who's going to add the further tests, add to waiting list, who's going to do that, ongoing referral, who's going to do that, who's going to tell the patient. That is the same, whether it's prostate, bladder, kidney, whatever. But the drop-down options are slightly different. So if you flick to the next slide, I'll just show you an example for this patient. So under where it says MDT discussion, the MDT coordinator will free type anything that we think is important that needs to be put there specifically for this patient. But when it comes to our overall management outcome, she can just choose one of these drop-down options. It saves her typing this over and over again. And if you flip to the next slide, a great example of this is look at the number of people that potentially might be telling that patient what's going on. That could be one of the urologists, one of the oncologists, one of the CNSs. It could be that we're actually going to tell them in the clinic. And before, she was having to type people's names over and over again, waste of time. So we've used a drop-down option now. So we flip to the last slide. So what's been the result of all of this? Well, the number of patients on the MDTs halved. We've freed up our non-cancer urologists to actually do some clinical activity, to operate, do some clinics, which our managers love on a Thursday afternoon. We've got better use of radiology and pathology consultants' time, which they absolutely love. Before, they used to dread the MDT. We've got quicker and more comprehensive MDT documentation. There's an audit trail, an electronic audit trail. There's none of this, I missed that email. And it's all there as well. By having the pro forma automatically uploaded to their EPR, there is less post-MDT admin or MDT repetition. What we used to all do after the MDT is scuttle off to our offices and then have to dictate a letter for every single patient to document the discussion that had happened in their MDT. So then when they were seen in clinic, we knew what we were doing for them. Completely pointless. What we've got is better improved pathways for the patient, particularly by having the post-MDT clinics and all of the admin working before of that to get it ready for that clinic. And by reducing the number of patients, ultimately, we've had a better quality of discussion per patient rather than just trying to get through it before home time. I think that's it.
Brilliant. Again, Elizabeth, thank you so much for that. Really, really interesting and insightful. Any questions for Elizabeth? Del.
Elizabeth, that's great. Thank you. A couple of issues that I want you to clarify, if you may. If you've kicked out 4 of your consultants, their names are still on the drop-down list to communicate with the patient the outcome of the MDT and the next steps. I think dropping out those who do not do cancer is one thing, provided that they never see cancer patients, to counsel them, to follow them up, because one of or to deal with their emergency admissions. One of the main benefits of the MDT, as far as I can see it, is actually continuing education to all the members of the MDT. And if they are not attending the MDT every week, if they are not attending the MDT, they wouldn't have this continuing education. So how can you deal with that if they are still going to do a TURBT, but it's not going to be of good quality because they don't know the importance of resecting the muscle or doing EUA and documenting it and so on and so forth. Also, if they are counseling patients about treatment or diagnosis for prostate cancer. So this is a bit that I wanted to understand, if you may.
Yeah, sure. So they're not on the drop-down list. If you don't attend the MDT, you don't do the MDT admin, you don't see the patient after the MDT. They come to specific clinics that are cancer interested urologists. Our urologists that aren't in the MDT do very little cancer work. They're mainly stone surgeons. They don't really want to be doing cancer work. They might see the odd raised PSA patient in outpatient clinic. And yes, you're right, they might do the odd TURBT because of patient pathways, and often they'll get pushed onto somebody's operating list because everyone can do a TURBT. Yes, they will do emergency TURBTs because we do have access to a urology emergency theatre every day. We're very lucky with that. So coming with clot retention, you might get an emergency TURBT. But I think they all keep up their own education anyway, as standard as anybody would, attending your meetings and EAU and BAUS and that sort of thing. They're all experienced urologists. They wouldn't know not to take muscle, etc. And we're all a very cohesive team. So if they had a patient they weren't comfortable with, then one of us would help them, or one of us would be around for advice. I think that actually overall, people are always worried about losing your practice and losing your skills. But actually, I think it was relief when we removed some of them from the MDT. They'd already said to me, I don't want to do cancer anymore. So I think it works better. I would rather have somebody who's interested in knowing what to do with your bladder or your renal cancer than somebody who doesn't know what to do with it, but is being told to be there.
Thanks, Elizabeth. I think that answers the question. Anybody else got any other questions for Elizabeth? Alison.
Hi, I'll ask a typical management question. Has this been rolled out to other MDTs in your trust?
In terms of using the proformas and so I know the head and neck MDT use it, and their MDT is incredibly efficient, even though they may only have small numbers of patients. Colorectal do it in a slightly different way. I think the problem is a lot of this is about personalities. So it's who's leading the MDT, who's the MDT coordinator, and what works well for one specialty might not work well for another, because obviously different specialties work in different ways. They were saying at the last meeting, the upper GI one still wants the benign pathologies to come back, and absolutely no way is a benign pathology coming back to my MDT. So yes, it's been shown in terms of cancer services have shown it out to other people and said this is what you can do. But it all comes down to essentially who's the cancer lead at the time to initiate that and who's the MDT coordinator.
Yeah, fair enough. Thank you.
Thanks, Alison. Thanks, Elizabeth. Naresh has popped a question in the chat. I'm going to invite Naresh to pop back up on the screen if you want to ask the question.
Apologies. Yeah, I'm really interested in those drop downs. They sound really an efficient use of time in the actual MDT, and also like a really good audit trail as to who's actioning the outcome. Do you have one saying for referring team or referring trust if the patient's under another service to action? Because sometimes that can get quite confusing with our MDT outcomes.
So if we are going to refer over to another trust, then we always see the patient in our post-MDT clinic to make sure that they are in agreement to go to another trust first. It's probably slightly different in London area. I know obviously your hub and spoke models, so it's slightly different, but obviously in a rural area like Cornwall, you have to check first that the patient's even willing to go to Devon. So yes, we would only ever do that through a clinic template. But I mean, it's a drop-down option. If the patient, if you know the patient's already willing to go the other direction in London, then yes, you have that as a drop-down option, and you could have it as a who's going to make that referral, or whichever way your pathway works. It's all doable, but as I say, it's going to work in different ways for different hospitals and different specialties.
Thank you.
Thank you, Elizabeth. Thank you, Naresh, again. So, any other questions before we wrap up? Looks like Pastor Duck has not been able to join us today, so he must be tied up with something else. So we'll a few more minutes for any other questions. If not, I will take the opportunity to thank Ketan in his absence. I think he's had to drop off the call, but I'll thank Ketan in his absence. Thank you, Naresh, and thank you, Elizabeth, again for joining us today. Lots of really great content, great questions again, really helpful discussion. I hope the rest of the people on the call have found that equally as useful and interesting. Lots of takeaway perhaps as well in terms of where you can introduce some of those thoughts and ideas into your own MDT practice. So really helpful. Thank you. Next session, session 4 is 29th of April. Hopefully we'll see many of you on that one again, 10 to 11:30. And that one's going to be on communication and leadership. So hopefully another great discussion, and bring lots of questions to that one again, like today. It's been really, really useful. If there's no other questions on Zoom, I'm just going to check. There's a question in the chat. Check it again. No, Thank you. Yeah, Crystal has popped the links on there to the Futures platform where all the presentations will be housed, and the recording will be on there as well as soon as Crystal's done her magic and sorted all that out. So pop back onto the site in an hour or two and you'll see all the content on there. But for now, enjoy the rest of your day. Hope you have a pleasant week, and we'll catch up again on the 29th of April.
Thanks all. Bye.